In continuation with the previous discussion, today we are going to discuss about the treatment modalities in COVID-19 positive patient who are admitted to the ICU. I am Dr. Swami Kausurmat, Associate Professor of Medicine, SDM Medical College and Hospitals.
Hi, I am Dr. Rajendra Parakh, working as Professor in the Department of General Medicine at SDM Medical College, Dharwad.
Sir, how you manage the COVID-19 patients with milder symptoms?
Okay, the patients, as I said, 80% of the individuals will present to us with a milder form of disease. If the patient present to us with milder form of disease, if they are running high temperature, we can manage it by just giving paracetamol. If they have dry cough, it can be managed with anti-cough remedies containing dextromethorphan. And ICMR has given green signal for hydroxychloroquine with azithromycin. If you are giving hydroxychloroquine, give it at a dosage of 400 milligrams BID on day 1, followed by 200 milligrams BID for remaining 4 days. You can add vitamin C to hydroxychloroquine, and if you are giving hydroxychloroquine and azithromycin in combination, remember that you monitor with EKG to look for QT prolongation. And considering oseltamivir at this point of time, if you are suspecting flu along with COVID-19, then you can consider adding Tamiflu. And a patient once having a milder form of disease has to be quarantined for at least 14 days.
Sir, how you manage the COVID-19 patients with moderate symptoms?
If the patient presents to us with moderate form of illness, this patient will be hypoxic at presentation. Your target SpO2 in such individuals should be 94% at presentation. These patients to be have watched very closely, because this patient can have a severe acute respiratory illness. This patient will be hypoxic. This patient will have a lower saturation. So this patient can be managed with oxygen with non-rebreathing mask with reservoir bag. You can give at least 10 to 15 liters with this modality. And remember that you should be fluid, when you're giving fluids, be conservative in giving fluids. And this patient can be managed with awake proning. And if the patient develops early ARDS, this patient will require a close monitoring in an ICU.
Sir, how the COVID ARDS is different from the ARDS of different causes?
If you consider COVID ARDS as compared to other causes of ARDS, this mainly COVID ARDS differs in lung compliance and lung shunt fraction. There will be a lot of VQ mismatch. As I said, the COVID lungs are very stiffer. It is a very heterogeneous disease because they can present to us with different phenotypes. The patient coming with phenotype 1 can progress to phenotype 2 and phenotype 3, or can halt at phenotype 1 and revert back. Remember, this patient can even present to us with phenotype 3 de novo, which carries higher mortality. These lungs have increased vascularity, and as I said before, these patients are prone to develop frank pulmonary embolism or micropulmonary embolism when you do CTPA.
Sir, can you enumerate the role of NIV and HFNO in severe illness?
When you consider NIV or HFNO as a modality in patient with early ARDS, remember these are the modalities where there will be a lot of aerosol generation and aerosol dispersion. So the plume generated out of this NIV or HFNO can traverse up till 1 meter. So healthcare personnel should be taking a full precaution. They should be wearing personal protective equipment. So considering NIV and HFNO can be tried early. As many studies have shown, high frequency nasal oxygen may be superior to NIV. But if you are using helmet NIV as an interface, so this can help in better oxygenation with NIV. But remember one thing, when you are using these modalities, you should always watch for NIV or HFNO failure. Don't waste your time. Closely watch for 3 to 6 hours. If they are failing on NIV or HFNO, you should go ahead and mechanically ventilate such individuals. Injudicious use of NIV, HFNO even after their failure, remember there's something known as self-perpetuating lung injury or self-inflicting lung injury, which will cause more damage to an individual rather than good to the patient. So what decides NIV or HFNO failure is if the patient has got high SAPS, Apache score being more than 17, SOFA score being high, P by F being less than 175, or the respiratory rate are going more than 30. This determines NIV or HFNO failure. Then straight away you should opt for invasive mechanical ventilation.
Sir, how you manage the COVID-19 patients with ARDS on mechanical ventilations?
Once you decide to put a patient on mechanical ventilation or endotracheal intubation, because again airborne precautions are of prime or paramount importance, intubation should be done by trained personnel only. So alternative equipment should be kept ready. Pre-oxygenation is important because at least for 3 to 6 minutes is important, because this patient, as I said, will not give enough time. This patient can desaturate very fast, and when you are intubating, it should be rapid sequence intubation. As much as possible, avoid bag and mask ventilation. Always use, after intubation, use closed suctioning, avoid nebulization, and don't disconnect circuit on and off, and change circuit or change HME filter only when they are soiled. Your primary goal when you intubate the patient, your primary goal should be lung protective strategies. You should minimize ventilator associated lung injury, or you should minimize ventilator induced lung injury. So as you consider again different modalities which have shown mortality benefit in patient with ARDS, you can follow ARDS net protocol, which tell you about low tidal volume. You can use low tidal volume around 6 to 8 liters per kg body weight and of ideal body weight, and you should use optimal PEEP, and always see that your platelets are less than 30. When you are giving fluids, you should be very conservative in giving fluids. They say that you should keep your kidney wet and lung dry. Don't overhydrate the patient. You can use neuromuscular blockade in the initial course of ARDS. Prone ventilation may be of importance in the patient who are not recruitable, who have P by F less than 150, or their P plat are going very high. And considering inhaled nitric oxide can be used in patient who present to us with phenotype 1, who are hypoxic because of hypoxic vasoconstriction, as nitric oxide is potent vasodilator, can be tried in phenotype 1. They have tried even in phenotype 2 and 3 with variable results. And if the patient is not doing good with prone ventilation, or patient is becoming more hypoxic, his P by F are less than 80, and the patient's lung are not recruitable, then you can opt for extracorporeal membrane oxygenation. If your center is well versed with ECMO, then you can go ahead with ECMO in such individuals.
Sir, what are the other manifestations of COVID-19?
As I said before, these patients are prone to develop a septic shock, and these patients should be managed as per guidelines given by Surviving Sepsis Campaign guidelines. These patients are even prone to develop acute kidney injury, and these patients may require dialysis at any given point of time when they are admitted in ICU. These patients are even prone to develop myocarditis or frank myocardial infarction, or they can even have a cardiac failure at presentation, so may require a cardiologist help. These patients, as I said before, these patients are even prone to develop a frank pulmonary embolism. There was one study done in Italy where 200 patients admitted in ICU, 25% of the patient had frank pulmonary embolism, 50% patient had micropulmonary thromboembolism.
Sir, can you tell about some experimental therapies?
Coming to the pharmacotherapy in patient with COVID-19, you got wide varied list of drugs, wide varied list of pharmacotherapy which are available. When you are planning to treat a patient with COVID-19, ICMR has given green signal for hydroxychloroquine to be used along with azithromycin, but caution is QT prolongation. Ivermectin, smaller studies have shown that it may be beneficial, but again no large data is available for its usage. Lopinavir and ritonavir in combination as an antiviral, studies which was published showed no benefits, but again requires larger randomized control trials to tell that it's being beneficial in patient with COVID-19. Tocilizumab, which is IL-6 inhibitor, can be used in patients who are critically ill, who have got lot of cytokine storm. This has been widely used in Italy and has shown some promising results. Coming to favipiravir, again it requires a larger studies or a robust data to tell that it's being beneficial in patient with COVID-19. Convalescent plasma was used in small number of patients, in five patients, which has shown a promising result. Again requires a larger studies to tell that it's being beneficial in patient with COVID-19. Coming to hyperbaric oxygen, I don't have any data at this point of time. may be of beneficial, but I think again requires larger studies to show that it's being beneficial in patient with COVID-19. Coming to vaccine, I think you still need to wait for vaccine till 2021 for the vaccine to be available at your disposal.
Thank you, sir. Thank you so much for the detailed explanation about the management and treatment modalities for the COVID-19 patient who admitted in ICU. I hope our doctors will take use of this presentation in managing the cases.
Thank you, Dr. Kasumat. It was pleasure discussing about treatment modalities in patient admitted with COVID-19. And before I end this session, I request all the healthcare workers to safeguard yourself, because your safety should be your priority and of paramount importance. Thank you.
Thank you.